lot of the things we're going to talk about in this section, we're going to talk about, or we already talked about. So, you know, it should follow that this should be a little bit easier than skulls. And the further we get into the semester, you know, the more we're going to repeat these things. So really the difference between the lateral, let's say for a skull, the lateral for facial bones, just central ray location collimation. Positioning still the same, interpupillary lines perpendicular. The infraorbital meatal line needs to be perpendicular to the front of the cassette, or, you know, the parallel to the long axis of your radiation field, all those things. Still the same, it's just central ray location collimation. You don't need to see the occipital bone for frontal bones, right? So central ray location collimation are really the only things. And we're going to start really on page 55, even though we've got nasal bones in a different section. I'm not real sure why we do, because, you know, it's a very commonly fractured facial bone. It is facial bone. And there is at least one question on the test on nasal bones. So we're really only going to do 2 views for nasal bones. One view is kind of a repeat. You have 2 nasal bones, so we're going to do bilateral laterals. But let's start before that with anatomy. So you got 14 in number, but for the most part they're going to be paired. You've got a left and right nasal bone, left and right lacrimal bone. Lacrimal bone, when you think lacrimal, back from your A&P, what are you thinking? Tears, yeah, so tear ducts. So naturally that's going to be kind of lateral to and posterior to the nasal bones, so they're on the inside of the orbit, and they've got a little canal that goes through them for the tear ducting, right? So that's where those are located. Very, very, very thin bones. And by virtue of how thin they are, they theoretically could be fractured very easily. I don't know that I've ever in my entire career seen somebody with broken lacrimal bone. But theoretically, because of how thin they are, they could be broken very easily. The nasal bones, on the other hand, stick straight out front. And your nose is a great big target for an airbag, for a fist, for the floor, if you know, you don't get your hands out in front of you. So in my experience, the nasal bone is probably most commonly fractured, followed by the mandible. But on the test, I think there's a question that asks, you know, which are, you know, thin and most easily fractured. That will be your nasal bones and your lacrimal bones. I would go even further and say in plain film radiography, you're probably not going to be able to diagnose a lacrimal bone fracture just because it's so thin. It just doesn't show up all that well. But again, in theory, it could be easily broken. So then you got left and right maxillary bones. So you got 2 separate ones that are fused together at midline, as are all of these as well. Palatine bones. All right, so your maxilla forms the anterior-most portion of your hard palate, your bone palate. And then the palatine bones are behind those. So the palatine bones posterior. Whenever we have a patient with a cleft palate, you see the commercials with kids with a cleft palate. What you're actually looking at in the deformity there in their facial bones is a failure of fusion of the maxillary bones. Okay, they may also have a failure of fusion of the palatine bones as well, but what you're actually visualizing is the failure of fusion of the maxillary bones. So both form the bony hard palate. You got the zygomatic arches or zygoma. We talked about zygomatic arches in the last section. The zygoma is your cheekbone. You've got the turbinates. We talked about that last time. You got a vomer, and that's continuous with the nasal spine. And then you've got the mandible. And the mandible we're going to talk about in a separate section. So they all look like this from the frontal side. Can you see that dark green thing right there? Okay, so that is your lacrimal bone. So it's actually posterior and lateral to both the maxilla and the nasal bones. Turbinates on the inside, nasal septum, and then you've got your, of course, your maxilla here, but your zygoma out to the side. All right, so we've kind of touched on these. So nasal bones, two small, thin, very thin bones stick out the front. They're fused in a lot of different places. The most obvious is going to be at the frontal bone. But they form the superior bony wall of the nasal cavity. And that's what forms the bridge of the nose between that and the suture at the frontal bone. So they fuse with each other, mid-sagittal plane, superior at the frontal bone, posterior superior with the ethmoid bone on each side, the maxilla. So they've got a lot of attachments. Even though it's a little bitty tiny bone, they got a lot of attachments. Lacrimal bones, we talked about those, and you don't necessarily need to know every attachment on all of these. Some of the attachments I want to talk to you about in context of fractures that are fairly common. So lacrimal bones, two smallest bones. We looked at where they are. They have that lacrimal foramen that we talked about, and their articulations are here: frontal, ethmoid, maxilla, and then the turbinates as well. So maxillary bones are the single largest immovable bone of the face, and it's the immovable portion is important. Your mandible is the biggest, right? But it moves. Hopefully it moves. Sometimes it moves too much. So each articulates with all of the other frontal bones except for the mandible itself. The mandible, the only articulation that you have, bony articulations with TMJ, so that's in the temporal bone. So it forms a lot of stuff. One is the lateral walls in most of the floor of the nasal cavity, and then it forms a part of the floor of the orbit as well. Directly below the floor of the orbit, we have maxillary sinuses. We're going to talk about those later in the semester. We call them, obviously the maxillary sinuses, but we also have another weird name for them, as what we refer to as the antra of Highmore. So we're going to talk about their position and the location of those sinuses in context of potential facial bone fractures here in a bit. So 3/4 of the roof of the mouth, so the palatine bones, they form the other fourth. Zygomatic process, it articulates or has a zygomatic process, articulates with zygoma to form the cheekbone, what we refer to as cheekbone. And then maxillary sinuses we already talked about. Infraorbital foramen is nutrient foramen, just for nerves and arteries to come through. Has the alveolar process, so that with mandible are the only bones, only facial bones have alveolar processes. Anterior nasal spine is where the two come together, the two sides come together, and they kind of push out just a little bit. That's at your acanthium. Okay, so your zygomatic bones are what we tend to think of as your cheekbones. So you've got the temporal process that reaches back just slightly to grab the zygomatic process of the temporal bone to form, your zygomatic arch. So articulations here are superior, you've got the frontal bone; lateral, you've got the zygomatic process, and then you've got articulation of maxilla and sphenoid bone. So the context of the fracture that I was talking about before is, have you ever, it could be somebody, again, got hit with an airbag real hard, or potentially, like in boxing or mixed martial arts or something like that, somebody said they broke their orbital bone. The announcer said they broke their orbital bone. Anybody heard that? Yes. Okay. So where's your orbital bone? You've got an orbit, right? But it's formed by a lot of different bones. There is no orbital bone. Generally what they're talking about is disarticulation of the zygomatic process, or zygomatic bone. So what happens, and they call it a tripod fracture, it disarticulates from zygomatic arch or zygomatic process, from maxilla and from a frontal bone, so it's just kind of hanging out there all by itself. So it's a a fracture of one of the bones that forms the orbit. Specifically, it's a disarticulation of the zygomatic bone itself. But there is no such thing as an orbital bone fracture. So from the side, got the nasal bones, we've got the maxilla, again, we've got the lacrimal bone, and we've got the zygoma here, and a mandible we'll talk about later on. So palatine bones we already talked about. It is what forms the posterior most part of the bony hard palate. Theoretically, you could have a cleft palate without having these two bones fused together. And again, you would still have a deformity. So the question on test asks failure, or cleft palate is failure of what bones to form or fuse?
Maxillary.
It's a maxillary. The answer on the test is maxillary. Don't get that wrong, okay? Answer on the test is maxillary. Could it also be the palatine bones? Oh, sure, it could, but the more significant non-fusion would then be the maxillary bone rather than the palatine bones. Palatine bones, just the posterior most 1/4. 3/4 of that bony hard palate is actually your maxilla. Okay. Okay, so and this is why I call them turbinates, is because I don't want to say conky, because I'm petty and I don't like that word. So they are the bones that, if you're looking at the skull, they kind of have that the things that kind of have that swirly appearance inside the nasal bones. So what they do is they're covered with mucosa, and that just increases the mucosal area, so that whenever you breathe in, whenever it's cold, it gives more surface area to warm the air up before it gets down into the lungs. So that's really more important than what you think it is. And I'm going to take a little bit of a divergence here. Who's been to surgery at one of the major hospitals? Okay, UT or Christus. So if they took you around, they might have shown you the trauma room. Okay, anybody walk into the trauma room? If you did, what's the weather like in there? It's about 90 degrees. Okay, so here's a kind of a non-related lesson, but something that you kind of need to understand in context of patient care, is that we've got these things that are air circulator blankets that are just real puffy, kind of look like one of those coats that has little air cells in them, Well, they get real thick. And what we'll do to try to keep the patient warm, if the patient's in a recovery room, is we'll put one of those things on them and then put a blanket on top of them, and then they have these heat generating air circulators, and they'll just, it probably works a lot like a dehumidifier. And it just circulates warm air through that thing, and the blanket on top, the cloth blanket on top, keeps the heat inside. Okay, so we use those for decades, maybe not that, for a long time, thinking that if a patient was in trauma, one of the complications of trauma is shock, right? So you want to keep the patient from going into shock. You have hypovolemic shock, and then if the patient gets cold, now you've got, you got shock on top of shock. So most of your ORs are cold. And that's to keep, if you ever find yourself in a situation where you dress out to help hold retractors or anything like that, you realize how hot all that stuff is. You're breathing into a mask, you got a thing on your head, you got extra clothes on that don't breathe real well because they're impermeable to keep the moisture off of you. It gets hot. So you want your surgeon to be comfortable, so they keep it cool inside. But the problem is that if you have a patient who's been in some sort of major trauma and they're headed towards shock and they're in a cold room breathing that cold air, then that blanket doesn't do them a whole lot of good. So what they learned was that a better way to keep a patient from accelerating into shock is to keep the air that they're breathing that's going down inside of their lungs hot. Okay? So when you walk into a trauma room and next time you do a trauma surgery, do surgery rotation, find out where your surgery suite is. And, you know, just walk into the room and see how hot it is. You'll start sweating almost immediately. It is hot. And that's why. And that's the purpose, again, for those turbinates to increase that mucosal lining to warm the air up before it gets down inside. If it's 68 degrees inside the OR, they're just not going to be able to keep up if the patient's already going into shock. So anyway, again, just a little bit of a divergence. So that's a conch shell. If you've never seen one, that's what a conch shell looks like. That's what a conch shell looks like on X-ray. All right, so the vomer is a thin plate of bone situated right at the mid-sagittal plane, and if you look in the nasal cavity, you can kind of see it. You can't really differentiate between the nasal septum and the vomer. You know, it's all pretty continuous. So posterior border is free. It articulates with perpendicular plate of the ethmoid bone. So all the way up from the very top at the coxcomb, the crista galli, all the way down to the bottom, that's one continuous bone. It's just broken up into different portions, you know, bony nasal septum, vomer, the perpendicular plate, all those things. They're not necessarily the same bone, but they're all fused together. Okay, so the orbit is a complicated little structure, and it's what I mean by there is no orbital bone. You've got a lot of different bones that make up the orbit. It's frontal, sphenoid, ethmoid, maxilla, zygoma, lacrimal bones, and palatine bones all go in to make up that orbit. And the orbit is kind of cone-shaped. I wish I'd brought a skull down with me. Orbit's kind of cone-shaped, where the back is kind of like the point of the cone, and the front is kind of a flare, where you know, if you're pouring something into a jar, you would put the back of this cone into the jar, and then you would, you know, the top, the fat portion would be sticking out. So it goes in a couple of different directions. One is that it goes medial and superior all at the same time. Okay? So a common fracture of the facial bones, in addition to the triploid fracture, is a fracture of the floor of the orbit. So that's the top, basically, of the maxilla. So what happens in these fractures, again, is if somebody gets hit directly in the eyeball with something solid like a baseball or a softball, or again, a fist, then what your eye is full of is kind of this gelatinous goo, right? We call it the aqueous humor, right? Now, basics for hydraulics is that you can't compress fluid. It's how hydraulic jacks work. You force fluid into a cylinder, and because it doesn't compress, it's going to pick stuff up. Hydrostatic pressure. If you've ever had a retaining wall that blows out, it's because the dirt absorbs water, and the water is going to push stuff out. If you've lived in the mountains, you've seen cracks in rocks. That's because ice gets in there, or water gets in there, and what happens when water freezes? It expands and it starts cracking rocks. Hydrostatic pressure is a very strong force. So if you get hit right square in the eye, racquetball, tennis ball, baseball, fist, whatever, then what's going to happen is the eye is going to distort, right? Because it's basically a ball of water. It's going to distort. So as it mashes in, it's not going to compress. It's going to expand somewhere else. And the floor of that orbit, and the top of the maxilla, is kind of thin. If you're looking at some of our real bone acrylic covered skulls, two things that you can look at. One's the lacrimal bone, and one is the top of the maxilla and the floor of the orbit. And they're so thin you can almost see through them. Okay? So what happens in those cases is because of that hydrostatic pressure, something's got to give. All right, so it's far enough back in the orbit that it's probably not going to affect the lacrimal bone, but it will absolutely affect the maxilla. That's what we refer to as a blowout fracture. So a blowout fracture is because of the compression of that eye and that hydrostatic pressure going somewhere, it blows out the floor of the orbit, and very difficult fractures to diagnose by seeing the fracture itself, because again, it's very thin bone. But what's directly beneath that? What'd you say?
Maxillary.
Maxillary sinus, right? So, it breaks out into the maxillary sinus, so the bone breaks out into the maxillary sinus, very also thin, mucosal lining in the sinus itself, it's gonna bleed. And so on our facial bone series, we're gonna look at the view, two views, that we can diagnose that. If suddenly the patient gets hit in the eyeball and they've got, on x-ray, they've got a maxillary sinus on the same side that's full of fluid, maxillary sinus should be full of air, then they've got one of two things going on. Either they've got a maxillary sinus infection that's just coincidentally in the same spot as, on the same side of the face as where they took that hit to the eye, or they've got a blowout fracture. More commonly, they've got a blowout fracture. It could happen that they've got a sinus infection previously already in that area, but more likely what happened is they've got a blowout fracture. So that's what it looks like. So we've got the frontal bone, we've got the ethmoid bone, we've got the lacrimal bone, we've got the inferior border of the maxilla, zygoma, and then we've got the greater wing of the sphenoid bone. So we've got orbital fissures, and that right there is the optic canal. The optic canal is almost at the apex of that cone, all the way back in the back of the orbit. So we have a specific view in order to visualize that. As far as the fissures go, we kind of looked at that in the exaggerated Caldwell views in the skull. If you want to see the fissures, you just increase the angulation 25 degrees, 30 degrees in order to visualize those fissures. Okay? So, where are we at time? That's plenty of time. All right, so this might be a short lecture today.
Is there going to be labeling on this test?
There is. Yeah.
Just mainly the orbit? And...
The orbit, and well, I think all three of those diagrams that we took a look at. So we've got the orbit, the real skull orbit on page 50 is a no. But back to the front of the chapter. So orbit on page 18, page 19, page 21. Okay, so, and we are going to add one view in here that's not listed here. It's what we refer to as a RESE. A RESE is R-H-E-S-E, RESE. And I think I've got it in the PowerPoints, but it is searchable online if I did not. But I want to describe it and tell you what it is we're looking for. Okay, so we're going to talk about the lateral nasal bones as well. We're going to talk about a Waters method. And we're going to talk about two of those. We're going to talk about the Waters and what we refer to as modified Waters. And anything you can do PA, you can do AP. And then again, we're going to recycle the Caldwell. The Waters is, in my opinion, maybe the most diagnostic image of the skull, and one of the very few that we should actually still be doing. Caldwell, whatever. PA, nah. Towns, maybe if we suspect a basilar skull fracture. Aside from that, just in that one case. But the Waters, we can diagnose a lot of stuff just off the Waters. We're going to take a look at those. You know I got opinions on just about everything, right? So lateral of the facial bones. Everything that we talked about on lateral before applies here. Again, the only difference is going to be central ray location collimation, collimate down just to the facial bone. So mid-sagittal plane parallel to the image receptor, interpupillary line perpendicular, infraorbital meatal line should be parallel to your collimated field, perpendicular to the front edge of the image receptor. You can do it with the patient laying down, you can do it with the patient standing up. Keep in mind that the patient, you know, they took a pretty good lick to the face, so use your best judgment as far as standing the patient up. Really kind of recommend sitting the patient down on something. They're going to be more stable sitting down as opposed to standing up. Less likelihood of them moving around if they're sitting down. So all the same stuff. In this case, the central ray is going to enter the lateral surface of the zygomatic bone about halfway between the outer canthus and the EAM. So instead of being 2 inches above the EAM, it's at the level of the EAM, and it's going to be more anterior. So what that tells you is two things. You don't need the occipital bone, and you don't need the vertex of the skull. What you're looking for in this case is a frontal bone. Now, you know, some texts will want you to include the tip of the mandible because it is a facial bone, right? So you might work with some people in, you know, I think Mindy, if not Mindy and Goldie both, will tell you to include the tip of the mandible, and that's fine. That's fine. If that's protocol, that's your protocol. What we're focusing on right now is not the mandible, but everything else. So I don't think that's a test on the question on the test to include the tip of the mandible. If it is, include the tip of the mandible. Okay? Because that's what Mindy and Goldie teach. So your radiation field is significantly smaller, 6 by 10. And you know, you can spend as much time as you want to dialing in your collimation, trying to get it at that 6 by 10, or you can put your central ray where it needs to be and then extend your radiation field about 1/2 inch beyond, you know, the anatomy that you want to see. So that's lateral facial bones. I said that we were going to talk about lateral nasal bones, and the positioning for the lateral nasal bones is identical to this. The only difference is that with the lateral nasal bones, I mean, how thick is that? Why do you shoot things in a bucky?
Reduce scatter.
Reduce scatter. You got a grid, right? How much scatter are you going to get off of that? Almost none, right? So with the lateral, if your order is just for nasal bones, you can shoot the nasal bones tabletop, or you can pull the grid out so that you're not shooting directly into the grid, right? But all you're looking for is a bone. It's a thin bone with almost no soft tissue on it. Your centering then is not going to be the same as the centering for this. It's just going to be basically, you know, bridge of the nose is pretty much a suture between the frontal bone and the nasal bones. It's right there, right? So your centering is going to be about 3/4 of an inch distal to that. Do both laterals, okay? So you're going to do a left lateral, going to do a right lateral. Which one is broken by looking at the patient? You really can't tell. You might think, well, you can tell because of, you know, if you're looking at the patient and their nose is kind of cocked over to the left, that's the left nasal bone. No, not necessarily. Could be both. So you're going to do both laterals, tabletop for lateral and nasal bones. Okay? The lateral of the facial bones looks like this. All right, so this is a little bit of a spoiler alert. Not really, but so can you see the nasal bones on this? It's labeled, but can you see them? The answer is no, you can't. This was probably an image that was taken on screens and films. So we didn't have a way to ferret out the contrast or the density for you know, low density structures with that. So if we got an order for nasal bones and facial bones, we had to shoot the lateral of the nasal bones separately. So if now you get an order for lateral or for nasal bones and facial bones, chances are you're going to be able to visualize the nasal bones on the facial bones. If you can, Don't waste a radiation dose. What are you shooting, even if you're shooting, well, let's start here. What are you shooting into on this patient that's radiosensitive? Orbits and thyroid, right. So, okay, so you shoot that, and let's say you can see the nasal bones well, right? So you reposition the patient and you collimate down. Your collimated field for nasal bones shouldn't be more than about 2.5 inches. They're short bones, little bitty bones, maybe 2.5 by 2.5, 3 by 3, something like that. But what are you still going to be blasting into if you collimate down to that? Central rays right there, you're still going to hit the eyes, right? So if you can see them well on lateral facial bones, I'll say this on a whole lot of things, but if you can see them well on lateral facial bones, just let it go, right? Don't go blasting the patient's eyes for lateral nasal bones if you can see the fracture on lateral facial bones. Okay, so parieto-acanthial, this is your waters. Again, probably at least one of the most important views of the facial bones. And I'll kind of give you a teaser into sinuses here as well. So we refer to this as a parieto-acanthial projection. So your projection comes from the vertex of the skull, or pretty close to it, and exits the acanthion. So we have two different waters. We have a modified waters and we have the original waters. The original waters, what we're going to do is we're going to take the patient and make sure don't have any kind of rotation. And what we're going to do is we're going to take the patient, we're going to put their chin on the image receptor. Okay, so the chin on the image receptor, the nose about a finger's width off of the image receptor. So our projections are the difference between the two, or what we're going to refer to as a not only modified waters and original waters being what we refer to as the 37 waters, modified waters being the 55. Let me get to them in the book. Okay, all right, so on page 61, that's the original waters. So what we've got there is that 37-degree angulation is the angulation between the orbital meatal line and the image receptor. Okay, this confuses a lot of people because if you flip back over to the Caldwell, 15-degree Caldwell, what forms that 15-degree angle? Central ray to the OML, okay? So they change your point of reference in this. And the point of reference here now is the image receptor and the orbital meatal line, okay? So don't let that confuse you. If you look at the image, let's see if I can bring it up here. If you look at the image, what you've got on the image is that you've dropped the petrous ridges down below the maxillary sinuses. Okay, so this kind of continuous big light blob of goo, that's your mandible, that's your petrous ridges, everything's stacked on top of each other way down there. Okay, so just looking at that, what do you see? Yeah, you see the maxillary sinuses. So what do you suppose your go-to view is to see the maxillary sinuses? Yeah, 37 waters. 37 waters. Let's see. Can you see the frontal sinuses?
Yeah.
Yeah, you can see them quite well. Is it ideal, as ideal as maybe a Caldwell to see the frontal sinus? Maybe, maybe not. But can you see them? You think you can make a diagnosis in that big head of cauliflower right there? Whether or not they've got a sinus infection or frontal sinus? Mm-hmm. Yeah. What do you suppose that is? It's a deviated nasal septum. Okay, so if they've got, a broken nasal septum, vomer, do you think that you could diagnose that? Probably so. So again, if they get hit in the eye and one of these fills up with fluid, we can diagnose, maybe not, we might not be able to visualize the fracture, but we can see evidence of the fracture. Kind of like fat pads that we talked about in upper extremity last semester, lower extremity last semester. Evidence that there is a fracture would be present in that full maxillary sinus. Also, and this is not the best image to show this, but follow this, okay? So we've got the lateral wall of the orbit down to this bone right here that kind of reaches back. Now imagine, you know, everybody's done this as a kid, lay it on your back, look at the clouds and try to pick out something in the clouds, you know, animals, whatever, right? So that's kind of doing this. That's kind of what we're doing here. It's this great, big, flappy looking thing here, the orbit. Okay. See this thing that kind of looks like, I don't know, it's coming off of the top of something, almost looks like a forehead. All right, in context of looking at the clouds. And then this thing comes down, and it's a skinny little bone that kind of expands down here at the bottom, but it's almost a standalone bony looking thing. Maybe it looks like an elephant's trunk, a little bit. Okay, so your waters, you know, the ear is the orbit, this is the forehead, and this would be the trunk. What do you suppose that trunk is? Zygomatic arch. So can you see zygomatic arch on this? The answer is yes. So you could diagnose a lot of stuff just off this one view. Frontal sinus infection, maxillary sinus infection, the evidence that the patient might have a blowout fracture, deviated nasal septum. It's not going to show broken nasal bones. Tripod fracture, it's going to show tripod fracture, and it can show zygomatic arch fracture as well. Okay, and as a bonus, you know, we can see the dens. So positioning is an awful lot like our Fuchs, right? Only this one is useful. Okay. Let's see, what else can we see from the map? Oh yeah. One other thing. So you have 4 sets of sinuses. So you've got the ethmoids, which are just a mess. You know, if they suspect a patient has a ethmoid sinus infection that needs to be diagnosed, that patient's going to CT. Because the ethmoid has a lot of different air cells. You can't, I mean, there's just no way that you can make a diagnosis. So we're just going to throw ethmoid out the window. We can diagnose a sinus infection here, and what's the 4th set of sinuses? Sphenoid, right. So if this patient were to open their mouth, you would see the sphenoid sinus through the open mouth. Okay, so we're going to see this view again in sinuses. For the maxillary sinuses specifically, open mouth waters for the sphenoid sinus. Okay, so we're going to recycle it twice in sinuses. So a very important view. All right, so we talked about that. Extend the chin and the neck, place the OML at a 37-degree angle, plane of the image receptor. If the patient can't get their head back that far, then you could angle your central ray, kind of like a Fuchs, to exit at the acanthium, or at the mental point. Yeah, I was going to have to default, thank you, I was going to have to default back to the peak of the chin. The mental point, thank you. Okay, so anything you can do AP, you can do PA. Anything you can do PA, you can do AP, right? So you can do a reverse waters, and all you would do is angle to the mentomeatal line, open your collimated field to about the same size, enter at the acanthion, and you should be golden. Okay, so if the patient's on a backboard or on a table or whatever, you don't want to flip them over, you can shoot at AP for your reverse waters. Okay, so that's reference what that looks like. I think this is on a Phantom. The reason I say it's on a Phantom is because things just look kind of weird, right? I mean, they almost look like they got bilateral sinus infections. But what are you not seeing in the foramen magnum there?
The dens.
In the dens. So this is either a complete internal decapitation or this is a Phantom, one of the two. And if it's a decapitation, I don't really know why we're looking for facial bones. The guy's dead. Right? Okay, so I'm going to take a little bit of a break here and talk about the Reese. All right, so the Reese, it's not in the textbook anymore because it's not on a registry. It's not on a registry because I don't really know why we ever had it, you know, as a positioning thing anyway. But some of our clinical sites still use it. So the Reese is a view where we can see the orbit and the optic canal within the orbit. So what we're going to do with the Reese is it's going to be a parietal acanthial oblique. Okay, and some people will refer to it as a three-point landing. And so what we're going to do is, let's say the patient's at the wall bucky. You're going to extend your chin kind of like a Waters. You're going to put the chin on the image receptor, and then you're going to oblique the patient's skull until the chin, the cheek, and the nose are on the image receptor. Three-point landing, chin, cheek, and nose. So put those three on the image receptor, and what you can do really is take a dry erase marker or something and put just a little X on the image receptor on the tabletop maybe, or if you're shooting into the wall bucky, just tell them where just show them where those crosshairs are on the wall bucky and say, I want you to put your eye right there. So they'll put their eye there and then extend it back until the chin, the cheek, and the nose are on the image receptor. Now I keep saying chin, cheek, and nose because what you're going to do, UT North, anybody? I think UT North still uses this, and that might be the only place it does. Okay, and what you're going to have a tendency to do is a year after graduation, you're going to forget chin, cheek, and nose, and you're going to go forehead, cheek, and nose. Okay, so if you put the chin, cheek, and nose on the image receptor, then what that's going to do is it's going to put the optic foramen in the lower outer quadrant, so quarter, right? So the orbit's round, and it's got, you divide it into quadrants. It's going to put the optic canal in the lower outer quadrant. Okay? Now, if you go with the forehead, cheek, and nose, what's going to happen is that's going to elevate the optic canal, and it's going to put it into the bones, and you're just not going to see it at all. So the view that you're trying to use to visualize the optic canal is not going to visualize the optic canal at all. So the thing that probably should go away, has gone away and off the registry, you're going to position wrong and not get it right anyway. Okay. Now you want to shoot this PA. Why do you want to shoot a PA?
Yes.
Yeah, put the eye closest to the image receptor, increase sharpness of recorded detail. But also, again, you're using the head and the brain as a filter, right? Orbit, radiosensitive, brain, not radiosensitive. You're going to put it closest to the image receptor. You're going to reduce the eye dose. Now, what if the patient can't, be prone? What if you can't shoot PA? Can you shoot at AP? Answer is yes. And it gets a little bit more complicated in doing so. Can I have a piece of paper, somebody, or index card, something? Are you going to use that again? Because I'm going to put it on my face. All right. So what if you have to shoot at AP? If you have no other option, then you got to shoot at AP. I'm getting this out here so I don't crack my head open. So your patient's laying down on the table, right? And you've got to accomplish all the same things, the positioning angles that you would have to for PA, right? So again, you'd have to oblique the patient's head 53 degrees, extend the chin 37 degrees, whatever, you know? I mean, do you have the protractors in clinicals to do all that? The answer is no. You probably have never seen one in clinicals. You might have seen one in lab, but you're not going to have that in clinicals. So what three things need to be against the image receptor? This might actually be too small, but I think I can make it demonstrate. What three things have to be on the image receptor to make this work? Chin, cheek, and nose, right? Not chin, cheek, and forehead. Chin, cheek, and nose. So you get the patient laying flat on their back. Yeah, I think that is going better. Since I didn't put this on my nose, you want this back?
Yeah.
Yeah. All right, so you get the patient laying flat on their back. You take a piece of paper and get their chin extended and head tilted, and you put it on those three things, chin, cheek, and nose. And when it's parallel to the floor, I'll get my P's out, parallel to the floor, then you've accomplished that, okay? And then you just center to the open orbit. Does that kind of make sense? Mm-hmm. Okay. It's a whole lot easier than trying to figure out that whole 53-35 thing. All right, so Caldwell, it's the same Caldwell we looked at before. Again, the only difference would be collimation and central ray location. Otherwise, it's the same. What is a Caldwell? It's PA projection with 15-degree caudal angulation, right? So if we increase the angulation to 25, it's no longer a Caldwell, but it's still a PA axial, right? So it's PA axial, 15-degree caudal angulation for Caldwell, 25-degree. Some people will call it a 25-degree Caldwell. For testing purposes, that's not a Caldwell, that's 25-degree PA axial, all the way through the registry. So we're going to rest the forehead and the nose on the table or whatever. So if we're truly shooting the Caldwell, it's going to be 15-degree caudal angulation, exits at the nasion. For orbital rims, 30-degree caudal angulation, exaggerated Caldwell, that's whatever. If that's what they want to call it, then fine. All right. So evidence of proper collimation, this should be what it looks like. You see that little thing right through there? That is your orbital fissure. Specifically superior orbital fissure. So we've got the orbits, we've got the Petrus ridges in the lower third of the orbits. And that's what it looks like. So zygomatic arches. SMV is the same SMV we looked at before. Again, the only difference here, there's three differences on this one. One is central ray location collimation. Two, there's central ray location collimation. And the other is what we're looking for now is, instead of the skull, we're looking for the zygomatic arches, so you can do this tabletop. It gives you more positioning latitude. It's easier to accomplish with the patient on the table. All right? Positioning wise, it's identical. Infraorbital meatal line needs to be parallel to the image receptor. If you can't get that, then your central ray needs to be perpendicular to the infraorbital meatal line. So your positioning latitude is that you can take the bucky out and you can shoot it tabletop. All right, so you got your patient laying on the table, extend their chin as far back as possible, and they can hold the image receptor, as it being parallel to the infraorbital meatal line, and you can shoot tabletop. You don't need to see the base of the skull, so there's no need to build the patient up or anything like that. So one difficulty that we run into with the zygomatic arches is that the arches don't stick out significantly from the side of the head, right? I mean, you're pretty well plumb here in most cases. Some people, their head is actually bigger than their face. Okay, they got the top of their head's kind of wide. And the problem with that is that if you do an SMV, you're going to project the zygomatic arches onto the parietal bones. You just can't see them. So it's one of the few exams that we're going to do that you might consider shooting at a lower SID. What happens when you have a lower SID? You get magnification, but what else?
Less sharpness. And
Less sharpness. But how might it benefit you? What's greater at lower SIDs when you decrease your SID to cover the same amount of image receptor? What do you have to do? You have to open your collimation. I think I heard somebody say. You have to open your collimation. Why? Because as SID decreases, divergence increases, right? So by decreasing your SID, instead of shooting at 40 inches, what you might want to do is shoot at 30 inches so that you've got greater divergence so that it will project those zygomatic arches out and away from the top of the head. You might shoot at 40 inches. If you don't get it, you know, let's say your positioning is perfect, but you can't see the zygomatic arches, now you might reduce your SID to 30 inches and see if you can project them out. Does that kind of make sense? A little bit? Okay. So, zygomatic arches. Again, tabletop, no reason to shoot them in a bucky. That's all you need to see is that right there, right? Most of your fractures are going to be depressed fractures like that. That would be the temporal bone where the zygomatic arch should plug into. Zygomatic bone is just depressed into the side. So if you have something where the entire bone is broken and pushed in instead of just a portion of it, and you can make a diagnosis on that. But if the entire thing is pressed in, you can't see zygomatic bone, or if the patient truly has. I went to school with a guy that, kids are cruel. This junior high school, everybody's mean. He had this bulbous head. A lot of people call it light bulb head. You couldn't. Yeah, that's funny, but it was awful. But anyway. You could not get a good SMV on this guy. You just wouldn't be able to do it, even with a reduced SID. So what we can do then to compensate for that is to oblique the patient just a little bit and do what we refer to as a tangential. Okay, so a tangential is kind of like an SMV, but it's unilateral, so we're only shooting one side. I keep closing my book to demonstrate. I want to draw your attention to the wording in the book because it is a little bit confusing. Okay, so on page 72, position of the patient. Seat the patient with back against the vertical grid device, place the patient in spine position. Hyperextend the patient's neck and rest the head on its vertex, top of the head. Adjust the position of the patient's head so that the IOML is parallel as parallel as possible to the plane of the image receptor. So you're positioning just like an SMV. And then it goes on. Rotate the mid-sagittal plane of the head approximately 15 degrees towards the side being examined. So if your interest is a right zygomatic arch, okay, so you got your head way back like this, right? You're going to rotate towards the side of interest, okay? We're looking at the right one. So then it goes on to say tilt the top of the head approximately 15 degrees away from the side being examined. This rotation and tilt ensures that the central ray is tangent to the lateral septum. Okay, so it just describes it. So then what you're going to do is you're going to tilt the head back, right? You're going to rotate 15 degrees towards the side of interest, and then you're going to tilt the head in the opposite direction. Okay? So it's rotation and then it's tilt. Okay? rotation, and then it's tilt. So rotate towards the side of interest and then tilt the head 15 degrees away from the side of interest. And I think I just tilted in the wrong direction. But tilt the top of the head away from the side of interest. So what that would mean is that if we're looking for the right zygomatic arch, tilt the top of the head, we're looking for the right, away from the side of interest. Yeah, like that. Okay? Of those two things, the tilt is the important thing. The rotation, maybe a little bit, might help a little bit. If you forget one, don't forget the tilt. The tilt is what's going to give you the zygomatic arch. Rotation just kind of keeps it more perpendicular, okay? Don't forget the tilt. All right? So that's your tangential. Again, tabletop, you're just looking for a little bitty bone. You can pull the bucky out. You can do this tabletop if you want to. Either way. Okay? So one more view. I feel like we can finish this up without taking a break. Y'all want to do that?
Yeah.
Okay. Because we're almost done. All right, so the towns, you can also diagnose zygomatic arch fractures. So again, the towns, what did we do with the towns? OML perpendicular, 30 degrees caudal angulation with the OML perpendicular to the image receptor. 37 degrees if the IOML is perpendicular to the image receptor. So positioning wise is identical. Again, the difference here is going to be central ray location collimation. We don't need to see the entire base of the skull, the vertex of the skull. So same things, 30 degrees, 37 degrees. Your collimation is going to be significantly smaller, 10 by 12 to get the entire towns on a skull, including the mandible. You almost have to use a 14 by, or 12 by 14. All right. So what then we're going to see are the zygomatic arches, just a tip in order to visualize those zygomatic arches and not overdose the patient. You might want to use -1 or -2 density. So these are the zygomatic arches. So now you got 3 possibilities on a patient with zygomatic arch fractures. SMV, tangential, towns. All 3 give you zygomatic arches. Okay? Any questions? Let me throw this in there. Because we talked about the blowout fracture. There are actually 2 waters. One is the original waters, 37-degree angle. Excuse me. The other is what we refer to as modified waters. That's on page 62. So modified waters, if you look at page 63 in the skull drawing positioning on page 63, and the skull drawing positioning on page 61, what's the difference between those 2?
37 degrees and 55 degrees.
Yeah, 37 degrees, 55 degrees, the nose is closer to the image receptor. So your positioning for the 55 waters is going to be with the nose and the chin on the image receptor. 37-degree waters, the chin is extended back so that you got about a finger's width in front of it. Okay? Now, why might we shoot the modified waters? Well, with the 37 waters, what we've got is the chin back so far that, let's say, you know, we've got a blowout fracture, okay? So a blowout fracture may look like, you know, if we put the floor of the orbit, I'm trying to get my fingers right here, floor of the orbit, there we go, sort of. Floor of the orbit is perpendicular to the image receptor. We might be able to visualize blowout fracture. 37 waters, we can't. Okay, the floor of the orbit's not perpendicular to the image receptor on 37 waters. So we might close that fracture. It's going to be a hard fracture to diagnose anyway, but 37 waters, the only thing that we're going to see is evidence the patient has a blowout fracture. 55 waters, on the other hand, takes the floor of the orbit and it puts it perpendicular to the image receptor. 55 waters, see the blowout fracture? Maybe. 37 waters, evidence the patient has a blowout fracture. Okay? So on your facial series, especially if they're concerned with blowout fracture, you may do both waters. This is a lateral. Depending on where the facial trauma is, you may do, you're always going to do at least one waters. Maybe both waters, always a lateral, possibly a Caldwell. And depending on where the fracture, the suspected fracture is, SMV. Can't see it on the SMV, take it on yourself to do the tangential. Okay? Any questions? That's all the facial bones in just over an hour. Good. I still got to look back at the skull test. There were 3 things on it that were a little bit squirrely. Number 3, number 63, and I think there was another one about a lot 67. Somebody said. What's your chair?
So the practicum is next week, correct? So do we? Cause Good Friday.
The practicum, yeah,
It's Wednesday and Thursday.
yeah, they'll have to contact you and
They sent
I don't
the
know what they're
schedule.
gonna do.
When they did the same thing where we were off Friday, they sent the schedule, so it's basically the same as that.
Okay, so it's just very practical instead of that.
they're gonna do it Monday and Wednesday, or
Wednesday and Thursday.
Wednesday and Thursday?
On the Reese, what, do we need to know like the,
Oh,
the centering and like?
yeah, centering's gonna be the orbit. The angulations, it's a 37-degree waters with a 53-degree head tilt. So that's 2. And 3 is where the optic foramen is going to be. That's going to be a lower outer quadrant.
Keep that in the video, so we can hear that again.
Okay, all right.
He's talking about something, and I said, make sure we leave that in there, just so we can have it, hear it again.
Got it.
Yeah, thank
All
you.
right.